Good evening friends, I am Dr. Oak again and welcome to my channel Critical Care Basics. This is the 34th ECG tutorial and the topic of today's ECG tutorial is atrioventricular nodal reentrant tachycardia, that is AVNRT. This is by far the commonest form of supraventricular tachycardia. So what is AVNRT? AVNRT is a regular supraventricular tachycardia that results from formation of a re-entry. This is mostly a micro re-entry circuit confined to AV node or perinodal atrial tissue. It is categorized as paroxysmal because it occurs suddenly, and QRS complex in AVNRT, like other supraventricular tachycardias, is narrow, that is less than 120 milliseconds or 3 small squares. That is because the ventricular activation is in normal sequence. SVT with QRS wide complex tachycardia with SVT can be due to rate related aberrant conduction or underlying bundle branch block. Rate related aberrant conduction I have already discussed in my previous lecture on re-entry. The link for this is given in description below. If you want to learn more about it, please see that video again. Let's discuss about the anatomy of AV node. AV node lies in the Cox triangle. This Cox triangle is bound by tricuspid valve opening on one side, the tendon of Todoro on the other side, and coronary sinus in the basal region. So this Cox triangle can be divided into 3 parts: the anterior third, the middle third, and the posterior third. The anterior third has the AV node and the fast pathways, and the posterior third has the slow pathways. This is important because whenever we require to do an ablation, this is mostly done in the slow pathway, that is the posterior part of the Cox triangle. Again, same repetition. This is the tricuspid opening. This is the coronary sinus and the tendon of Todoro. This is the fast pathway, this is the AV node and the slow pathway. This is how it looks in the heart. This is the coronary sinus and this is the tricuspid valve opening and this is the tendon of Todoro. This is the area of the AV node. Now, AVNRT could be typical or atypical. It is called typical when the ventricular activation or antegrade flow of the current is through the slow pathway, and the retrograde activation of the atria, that is re-entry, is through the fast pathway. I will explain. Normally, whenever there is a impediment to conduction, we have discussed this in re-entry. Let's review it. Whenever there is an impediment in the conduction within the AV node, there are 2 pathways by which the current can go. One is the fast pathway. This fast pathway takes the current faster, but it has a longer refractory period. And slow pathway takes the current slower, but has a short refractory period. So whenever the impulse comes through the atria, it goes via the fast pathway. Whenever the normally timed impulse comes from the atria, it goes via fast pathway and goes to the ventricles. It also slowly goes to the slow pathway, but when the impulse reaches the ventricle, it retrogradely goes through the slow pathway and the 2 impulses cancel each other. So we get a normal sinus rhythm with P wave, normal PR interval and the QRS complex. What happens if this impulse comes before time? What is called as an atrial premature contraction. So that time this fast pathway is now refractory. So the current now goes through the slow pathway and it goes through the ventricles through the slow pathway. Because it goes through the slow pathway, it takes more time. That is why the PR interval is prolonged. By the time it reaches this point, it goes to the ventricle. Simultaneously, if this pathway, fast pathway, has recovered, this current goes upstream retrogradely via the fast pathway and reactivates the atria. When this impulse turns around within the AV junction and reactivates the same chamber, this produces what is called as an echo beat. So how can you differentiate whether this supraventricular tachycardia is AVNRT or something else? In the beginning of AVNRT, you will see atrial ectopic with a longer PR interval, which is called as PR jump, and followed by an echo beat. Same repetition. This is the normal current, normal impulse which has come at the normal time. It goes fast via the fast pathway, and it also travels through the slow pathway, but that is cancelled from the current coming in the opposite direction, giving us a normal sinus rhythm. Now impulse has come earlier, so this is atrial premature contraction. It goes through the slow pathway because the fast pathway is refractory, and it does come back via the fast pathway, but the fast pathway is blocked here. Now if this pathway conducts the impulse towards the atria, then this forms an echo beat, right? So this impulse came to the AV node, fast pathway was refractory, went through the slow pathway, went to the ventricle. Because it passed through the slow pathway, the PR interval is long, and it went up through the fast pathway, giving rise to echo beat. And if this continues, so it will give rise to AVNRT, atrioventricular nodal reentrant tachycardia. What you notice here is this P wave or echo beat comes immediately after the R. So the RP interval is short. The supraventricular tachycardias are divided into short RP interval tachycardias and long RP interval tachycardias. So this is a typical AVNRT is an example of short RP tachycardias. So this can help you to diagnose. We have depicted the same in the ladder diagram. This is the normal beat giving the sinus beat. It has come, the impulse has come from the atria. In the AV node, it has traveled through the fast pathway and gone to the ventricle. Again, normal sinus beat. This third beat, A2, this is an atrial ectopic because it has come before the normal beat should have come. The fast pathway is now refractory, so it goes through the slow pathway, it goes to the ventricle, giving rise to a longer PR. At the same time, it goes back upwards through the fast pathway, causing what is called as AVNRT. So this is the typical slow fast AVNRT. Why it is called typical? Because we have defined typical as that AVRT where the antegrade conduction of impulse from the atria to the ventricles is through the slow pathway and the retrograde conduction is through the fast pathway. So this accounts for 80 to 90% of all AVNRTs. Here the retrograde P wave is obscured in the corresponding QRS. So you may not see P waves at all. That is the most common occurrence. Or you could see P wave as a small bump after the QRS. So especially in V1, like this is, you could see a small P wave just after the QRS, because this is not an actual R wave or R prime wave, but looks like a positive deflection. That is why it is called pseudo R prime wave. Similar negative wave you can see in the inferior leads. So this is pseudo S wave. I depict with the example. Now this is a patient who has developed sudden tachycardia. You can see the heart rate is about more than 150. This is a narrow complex tachycardia. So this is supraventricular tachycardia. And see what is happening here. This small positive deflection here, that is coming after the R. This is called as second R or pseudo R. This is actually the P wave, the echo beat. So this is called as small R prime. And you can see similar pseudo S wave here, right, in lead 2. So pseudo R waves in lead V1 and pseudo S waves in inferior leads 2, 3 AVF. So this is typical. AVNRT. Now atypical AVNRT, this is fast slow AVNRT. Here the antegrade conduction to the ventricles is through the fast pathway and the reciprocal or retrograde conduction is through the slow pathway. This is rare, 10% of AVNRT. Here the retrograde P wave appears after the corresponding Q wave because the retrograde flow of the current is through the slow pathway, hence the P wave is delayed. Hence the P wave comes after the QRS, it comes somewhere between the QRS and T. So P waves are visible between the QRS and T wave, so that means the RP interval is longer than PR, so that is long RP tachycardia. This fast slow or atypical AVNRT can be precipitated by a ventricular ectopic. Like we said, this typical AVNRT is precipitated by an atrial premature beat, while the fast AVNRT is precipitated by a ventricular ectopic. See, this is a ventricular ectopic here. This is a ventricular ectopic, and what happens? It tries to go from, the current tries to go up, but the fast pathway is refractory, so it goes slowly through the slow pathway, and by the time the current reaches here, the fast pathway has recovered and the current comes back fast. So see the QRS complex and the P wave quite late after the QRS complex. Again, this has been depicted in the ladder diagram. This is the normal sinus beat, and now this is the ventricular ectopic. Because the ectopic current went up through the slow pathway and then it has come back through the fast pathway, causing a P wave that is that comes after the QRS complex. Now here you can notice the QRS complex and the P. So the distance, the RP distance is definitely more than the PR distance. So this is long RP tachycardia. So antegrade conduction is through the fast pathway and retrograde conduction is through the slow pathway. Because the slow retrograde activation of the atrium, the P wave occurs after the QRS complex. This is long RP tachycardia. Now this slide I have already discussed in my earlier lectures, but it would be prudent to discuss it here because we have to diagnose which type of SVT it is, whether it is AVRT or AVNRT or focal atrial tachycardia. Now what we have to see in any supraventricular tachycardia is whether this RP interval, the P coming after R, is shorter or longer than the PR interval, right? For example, this is short RP tachycardia, the R, and immediately there is P wave. The short RP tachycardia is typical AVNRT and even most AVRT, that is atrioventricular reentrant tachycardia. Most of these tachycardias, typical AVNRT and most of AVRTs have short RP tachycardia, while long RP means the distance between the R and P is longer than distance between the P and the next R. So that is long RP tachycardia. Long RP tachycardia can be sinus tachycardia, focal atrial tachycardia, atypical AVNRT, and even some atrioventricular reentrant tachycardias. Now the least common is slow AVNRT. So here the antegrade conduction is through the slow fibers and the retrograde conduction is also through perinodal slow left atrial fibers approaching the AV node. So here what happens? Tachycardia with a P wave seen in the mid diastole. Effectively, so P wave comes later in the mid diastole. Effectively, P wave comes before the following QRS complex. So it just looks like a sinus tachycardia. So it is difficult to distinguish from sinus tachycardia. Now these are the two most common causes of supraventricular tachycardia: atrioventricular nodal reentrant tachycardia that we are discussing now, and atrioventricular reentrant tachycardia that we are going to discuss in next lecture. Hence, I have in this chart tried to differentiate how to distinguish between the two common forms of supraventricular tachycardias. atrioventricular tachycardia, atrioventricular nodal tachycardia, the mechanism is micro reentry, while in atrioventricular reentrant tachycardia, the mechanism is macro reentry. There is an accessory tract and the impulse can come through the normal AV nodal and His pathway route and go back via the accessory route, or it can come through the accessory route, which is called as antidromic, and go back through the normal sinus path. So this we are going to cover in the next lecture, but still in AVNRT, like we discussed, it is, if it is typical, which is most common, now it has to be a short RP tachycardia. So if the RP interval is more than 70 milliseconds, it is very unlikely that this tachycardia should be AVNRT. Also, AVNRT also usually it is the short RP tachycardia. Here the QRS is usually narrow unless there is bundle branch block or rate related aberrancy. Here, if it is orthodromic, the AVRT can be orthodromic or antidromic. What is orthodromic? Orthodromic means the current is coming from atria to ventricle via the normal AV node His Purkinje system, but it is going back to the atria via the accessory path. In this condition, the QRS will be narrow. But if the current impulse is coming through the accessory tract from the atria to ventricle and then going back via the AV node, then in that condition the tachycardia would be wide complex, right? And you can use adenosine to differentiate. If you give adenosine and the tachycardia recurs, you can see a long PR before the AVNRT starts again. So that is called as PR jump. So if you can see PR jump in a short RP tachycardia, you can see PR jump during initiation, then it is most likely to be AVNRT. In AVRT, if you see evidence of pre-excitation, what is the evidence of pre-excitation? In my next lecture, we are going to discuss about AVRT and WPW syndrome. So pre-excitation means there is short PR and a delta wave. So if the evidence of pre-excitation is seen, almost always that is due to AVRT. Now, what are the symptoms? Most common symptom is palpitation. Some people can have dizziness, breathlessness, chest pain, fatigue, syncope, and even sudden cardiac death. Sensation of chest pounding if atria contracts in a closed tricuspid wall. Normally, atria contract at the end of ventricular diastole, right? So, but if atria contract while the ventricles are still contracting, the tricuspid wall is closed, and that leads to filling of the interjugular vein and a sensation of chest pounding. This is the Frock sign. The interjugular vein suddenly fill because atria are contracting on a closed tricuspid wall. This is also called as Canon A waves. These waves are also seen in AV dissociation. What is the ECG finding? We have already discussed. Just summarize. It is a narrow complex tachycardia unless there is aberrancy or bundle branch block. The ventricular rate is between 120 to 220 per minute. There is abrupt onset following a PAC. If you can document it, nothing like it. If you can document an abrupt onset, atrial premature contraction, then a long PR, that is PR jump, followed by supraventricular tachycardia, then it is most likely to be a AVNRT. Typical AVNRT is a short RP tachycardia, while atypical AVNRT is a long RP tachycardia. We have already discussed. Same ECG, I have repeated again. This is a typical AVNRT, sinus tachycardia, narrow QRS, and short RP. You can see after R, immediately there is P, that is R prime is P. So short RP tachycardia, and pseudo are in V2 and pseudo S in lead 2. Now, atypical AVNRT, which is also called as fast slow AVNRT, the retrograde atrial activation occurs long after the ventral activation, because the current that goes back to the atria is going through the slow pathway. It takes longer time. So the P wave appears quite late, right? So this pattern resembles, this is a long RP tachycardia, and sometimes it can mimic a focal atrial tachycardia. So you cannot easily distinguish, you need a EP study to diagnose. Now, a relation of P to QRS can help in diagnosis of AVNRT. The most common form of AVNRT is this. No P waves are seen, just narrow QRS tachycardia. This is the case in 66% of patient. Then you can see pseudo S waves in 30% of patient. You can see pseudo Q waves, that is P wave appearing inverted before the QRS in 4% of cases. Sometimes retrograde P waves after the QRS. This is rare. And in atypical AVNRT, the P waves appear quite late than the QRS. So this is a long RP wave already discussed. There are 4 main differential diagnoses in AVNRT. One is sinus tachycardia, but sinus tachycardia there is gradual onset and gradual offset, right? It doesn't occur suddenly, paroxysmally, and it is usually in response to some condition, fever or many causes of tachycardia, and this is a long RP tachycardia. Then second is focal atrial tachycardia. This is again a long RP tachycardia, but it is paroxysmal, sudden onset. P waves can come before or after QRS. Then third is AVNRT. AVNRT is also short RP tachycardia. It is not easy to distinguish, but if you see an evidence of pre-excitation, that is short PR and a delta wave, then you can distinguish with certainty that this is AVRT. And lastly, junctional tachycardia. This is rare. This is seen in children, should be suspected when there is no ventriculoatrial block. When there is ventricular atrial block, that is, you cannot see inverted P wave or anything like that during the tachycardia, and when the tachycardia is initiated by a premature junctional beat, right? Now we have a patient with AVNRT. A patient has supraventricular tachycardia, narrow QRS tachycardia. What do we do? How do we treat this patient? So you take the patient on bed, take the vitals, connect the monitor. Now you have to first see whether the patient is hemodynamically unstable or not. How do we see whether the patient is hemodynamically unstable? Patient has BP 90 or less, patient has sweating, or patient has fainting, or patient has impaired mental state. In that case, if this is the condition, then the treatment of choice is electrical cardioversion. You can start with 50 joules and take 2-3 attempts, then switch to 100 joules, 50 joules, 100 joules, 100 joules. If the AVNRT is still refractory, then you can consult an expert cardiologist, and you can also consult the ACLS guidelines. If the patient is hemodynamically stable, then first try vagal maneuver. So if most of the tachycardia, sometimes they improve or subside with vagal maneuver. If the arrhythmia is persistent, then try IV adenosine. How do we give IV adenosine? It is given by a Venflon, which is connected to a three-way, and from one end you give IV adenosine push 3 mg or 6 mg, and from the other end you push 20 ml NS, and then raise your hand immediately, so that adenosine reaches the heart very fast, because it is very short acting. So if it doesn't work with 6 mg, you can give another dose of 12 mg. If it is still resistant, if the AVNRT or supraventricular tachycardia still persists, you can try beta blocker or non-dihydropyridine calcium channel blocker like diltiazem or verapamil. If still the arrhythmia persists, then you can go in for electrical cardioversion, or you can consult cardiologist. Now, suppose the patient has tachycardia, it has responded with probably a drug or electrical cardioversion. What do we do now? Do we give preventive therapy so that it should not recur again? So it depends on what is the frequency of arrhythmia. Is it appearing, is the patient experiencing recurrent bouts of tachycardia, or if the patient has severity of symptoms, he or she is fainting or has heart failure, or Can the patient tolerate medicine? Some people can have severe constipation with diltiazem or other side effects with beta blockers. So whether the patient is able to tolerate this medicine. And lastly, patient preference. Some people do not like to take medicines. No treatment if the patient can avoid to take some preventive tablet if the attacks or the episodes of AVNRT are infrequent and patient tolerates them well. So he doesn't have syncope or severe giddiness, or the patient doesn't land up in hospital. If a patient is relatively tolerating this episode well, and patient can decide as to he can do his own vagal maneuvers and he can come to the doctor when required. If the patient is educated, you can continue the patient without any treatment. The best treatment is catheter ablation. So what are the indications for catheter ablation? If the episodes are occurring very frequently, if they are refractory to medical treatment. So we are giving, say, diltiazem, but the patient is not responding, having episodes, and the episodes are poorly tolerated, associated with syncope or pre-syncope or angina or severe breathlessness, and result in presentation to the emergency department, or they require hospital admissions. So if the condition is quite severe, then the treatment is catheter ablation. Now we have already discussed this anatomy of AV node. The definitive treatment is ablation and the success rate is 95%. The risk of AV block is very small, about 1%. The ablation is usually targeted on the posterior 1/3 of the Cox triangle, where the slow pathway. So ablation is done on the slow pathway usually. If the patient is not willing for ablation or is not a candidate for ablation, then such patient can be continued on chronic suppressive therapy. The choices are beta blockers or non-dihydropyridine calcium channel blockers. The most commonly used is diltiazem. The second is verapamil. That is all about AVNRT. I hope you are liking these videos. If you are liking, please subscribe and give a thumbs up. In next lecture, we'll talk on atrioventricular reentrant tachycardia. Bye-bye.